So this is the iWiMS Clinical Trials Conference. So our first presentation is from a group in Belgium. So the title of their presentation is MACSiMiSE-BRAIN, a Metformin Add-on Clinical Study in Multiple Sclerosis to Evaluate Brain Remyelination and Neurodegeneration. Will be presented by two trainees. We have Anne Victoria, who's a medical doctor, who's a neurology resident at the University Hospital of Antwerp. And then also Eline, who's a neuroscientist working at the University of Antwerp, and who both started working on this project as PhD students. And Anne Victoria will focus more on the clinical aspects, and Eline MRI analyses to assess repair and remyelination. And they're supervised by Barbara Wilkins, who's a senior neurologist at the same institution, who's been a neurologist since 2006, and has a PhD in 2021 and doing research focused on understanding CNS neuroimmunological diseases and novel treatment approaches. So thank you and welcome, and you can share your slides.
Okay. Oh, I will just wait a second. We tried it a couple of minutes ago and then it worked, but now
if it comes up that way, you can click. There is a spot to swap screens.
Yeah.
And if you just click to see the double arrow at the top, usually that's to swap screens.
Yes. Okay. Perfect.
Perfect. Thank you.
I see that Dr. Wilk is also just joined, so just in time. Okay, so thank you for the introduction. Me and Anna Victoria, we will give you some more information about our upcoming clinical trial, the MACSiMiSE-BRAIN study. It will be a Metformin Add-on Clinical Study in Multiple Sclerosis to evaluate brain remyelination and neurodegeneration. Currently, our study protocol is still pending for approval by the regulatory authorities, but we are hopeful that we will be able to start in the upcoming months. Of all MS patients, more than 50% eventually evolve into a progressive disease stage, which gets characterized by an increase in both physical and cognitive decline. And as you all know, probably the main driver of this disease progression in MS patients is axonal damage caused by the inflammatory process, which instigates demyelination. And in progressive MS patients, the subsequent and very crucial remyelination fails or is insufficient. And as you all know, for relapsing or remitting MS, there are currently a number of disease-modifying therapies on the market. And these DMTs, they can control the inflammatory process, but however, they cannot specifically target non-inflammatory disease-related mechanisms, like, for example, remyelination. And this makes that when the initial inflammatory course of the disease evolves into a more progressive one, the treatment options become very limited. And therefore, there is high unmet need for therapies which can specifically target the processes underlying the disease progression in non-active progressive MS. So in periods without frequent inflammation. So we need therapies that can, in this period, ensure remyelination and axonal protection. And with this study, we put forward metformin as a novel therapeutic option that can possibly do this. So that can possibly slow down or even stop the neurodegeneration underlying this disease progression. But yeah, why metformin and how can it do this? If we want to slow down disease progression, then remyelination is the key. Remyelination is an endogenous and regenerative process, but like most regenerative processes in the body, the efficiency of this process declines with aging. And if we look at disease progression in MS patients, we can see that the age of onset is similar in all patients, regardless of the disease course. And this underpins the idea that age and aging of cells is associated with neurodegeneration and thus disease progression. And oligodendrocytes are also cells that fall victim to this aging of cells. In animal models, we see that their precursor cells, the OPCs, are present in MS lesions, but however, they fail to differentiate into oligodendrocytes that can form new myelin. So if there would be a way for these OPCs to be immersed into a more youthful systemic environment, then remyelination could potentially be enhanced or even restored. And it has been proven that one of the ways to improve OPC function and thus remyelination is fasting. Dietary restriction is a very effective intervention that can enhance the function of aged cells. And in animal models, it has been shown that an alternate day fasting schedule can lead to rejuvenation and rejuvenation of these OPCs and thus remyelination. However, fasting protocols in clinical contexts are difficult and, to be honest, also not really pleasant for patients. So this is where metformin comes into the picture. Metformin is a drug that has fasting mimicking effects, and it has been put forward as a potential anti-aging drug. It has been on the market for more than 20 years, and it is traditionally used in type 2 diabetes patients. Multiple studies in different animal models have provided proof of concept of the positive effects of metformin. It can indeed improve and protect OPCs, but it has also shown antioxidant, antifibrotic, and immunomodulatory effects. A pilot clinical study in obese patients with relapsing remitting MS has already confirmed the preliminary safety of metformin in this specific patient population. Another cohort study in MS patients showed that type 2 diabetes and therefore using metformin, those two characteristics were both associated with a decreased risk of disability progression. So therefore, for these reasons, metformin was recently shortlisted by the UK MS Expert Consortium as a highly promising repurposed drug, and it was recommended by them for immediate use in clinical trials focusing on progressive MS. And that is exactly what we will aim to do in this clinical trial.
So Eline has talked to you about why using metformin. I'm going to talk about how the clinical trial is going to be conducted. So MACSiMiSE-BRAIN is a multi-center, double-blind, placebo-controlled clinical trial that will be conducted in both academic and non-academic clinical trial centers, 5 in total, all over Flanders. Our estimated sample size is 120 patients. Our goal is to determine whether metformin as add-on treatment in patients with non-active progressive MS can delay disease progression in comparison with placebo. And we will measure this by our primary outcome measure, the change in walking speed, the time 25-foot walking test. This is a schematic overview of the timeline, where you can see that patients will be randomized in either the intervention group or the placebo group at baseline, and they will be followed up over a period of 96 weeks. They will be followed clinically and radiographically in a frequency that is equivalent to clinical care. There are 6 on-site visits where patients will be tested clinically, where they will fill in questionnaires and blood samples can be drawn. And there are 3 on-site visits where patients will have a brain MRI. Then you can see there are 4 remote telephone visits, and during the clinical trial there is a continuous adverse event reporting. For the inclusion and exclusion criteria, there's a lot of information on these slides, but I will just highlight several points. So patients should have a diagnosis of non-active progressive MS. This includes secondary and primary progressive MS, as evidenced by no relapses, no new T2 lesions, and no enhanced T1 lesions on brain MRI in the past year, so NIDA2, and a progressive disability independent of relapses in the past year or longer. Patients aged 18 till 70 years old. Patients should have an EDSS of from 2 till 6.5, because they need to be able to do the time 25-foot walking test. They should be Dutch and Flemish speaking, because the questionnaires are in Dutch. And I will highlight that their use of DMT should remain stable throughout the clinical trial. Then for the exclusion, it's important that patients do not have a diagnosis of diabetes or have a fasting glucose level more or equal to 126 milligrams per deciliter, or a random glucose level more or equal to 200 milligrams per deciliter, or an HbA1c more or equal to 6.5%. As I mentioned before, patients should not be undergoing immune reconstitution therapy or change their DMT. And of course, patients who already are on metformin or have a known intolerance to metformin cannot be included. And then I would like to point out that patients should not start fampiridine or for aminopyridine or keep their dose stable. And also the physical therapy should remain stable throughout the clinical trial. Then as outcome measures, as I've mentioned before, we have chosen for the primary outcome measure, the time 25-foot walking test, because it is known that at least 20% change is regarded as a clinically meaningful outcome. As a secondary objective, we hypothesize that metformin can delay disease progression in several domains. So in general disability, but also in cognitive function and in hand function. And we hypothesize that this clinical effect will be supported by slowing down disease progression and improving remyelination on brain MRI. So as clinical outcome measures, we have chosen for the EDSS, the SDMT and 9-hole peg test. And for brain MRI outcome measures, we have chosen for MRI volumetrics and DTI. And then as a tertiary outcome measure, we have chosen for patient-reported outcomes and caregiver-reported outcomes, because we hypothesize that if metformin can delay disease progression, this will result in a stabilization or an increase in quality of life and a decrease in caregiver strain, and that it will be cost-effective. And these things will be assessed with questionnaires. And I would also like to mention that as a tertiary outcome measure, we will assess iron rim lesions on MRI. Then to end, I would like to say that we have received funding for a sub-study, a centralized biorepository for biomarkers, because we as a research group, we like to improve our understanding of disease mechanisms by investigating emerging biomarkers for disease progression. So NFL and GFAP, our goal is to investigate these biomarkers in the serum of our patient population. And we would also like to set up a biorepository for future research. So what we will do, we will assess the serum concentration at baseline and correlate this with clinical and MRI outcomes. And we will measure the absolute and mean change in both the placebo and in the metformin group at year 1 and year 2, and compare this with baseline. And this slide shows again the timeline, where you can see that at several time points, a blood is drawn from the patients. So at these time points, it's also possible to draw additional blood samples for the sub-study. So we do not believe it will be a problem to include patients for this sub-study.
And then to conclude, what will in summary be the clinical relevance of this project? As we all know, progressive MS, it poses an enormous burden on the patients, on the caregivers, but also on the healthcare system. And our project will aim to validate the therapeutic use of metformin, because establishing a treatment for progressive MS would really mean a breakthrough for healthcare in this chronic disease on many different levels. For example, firstly, by stopping or slowing down disease progression, patients and their surroundings would benefit by an improved or stabilized quality of life and functioning, both in the personal as in the work-related environment. And next to elevating the personal burden of MS, there could also be societal benefits, because the annual costs for society, they steeply incline with increasing disability. So avoiding disability progression, even to some extent, can lead to big cost savings for society. Secondly, the knowledge that will be gained in this clinical study can shed more light on the mechanisms underlying progressive MS. Our aim will then also be to spread this knowledge to healthcare workers, but also to the scientific community and to the general public. And on top of that, we also aim to standardize and validate MRI biomarkers in progressive MS. Because to date, progressive MS remains a clinical diagnosis through follow-up of clinical examination. So MRI biomarkers that can help in defining therapeutic response will also be proven to be useful in a day-to-day clinical practice. And then thirdly and lastly, we also will improve cost benefits by drug repurposing, because when developing a new drug, it's very expensive, both in terms of money as in time. And by repurposing an off-patent drug for another indication, this can be done at a much lower cost. Because mostly, all the preclinical work has already been done and does not have to be done again. And when also taking into account a very low cost for the use of metformin as an add-on therapy for patients, one tablet of metformin costs around 10 euro cents. Because of this low price, even a small effect size in this study will also prove the cost effectiveness of the therapy. And with this, we would like to conclude our presentation about the upcoming clinical trial. We would also like to thank all the contributors to this project. We look forward to starting the project, and we would be happy to answer any questions if there are some. Thank you.
Thank you very much. Yeah, sounds like a very interesting study we all want to hear the results for. Any questions from the audience? You can put it in the chat or you can unmute.
Yeah, I'm Emmanuel Beaumont, UCSF. Very good to hear about that study, very well designed. The main question I have for you is whether you have started enrolling patients already in the study, or whether you're just planning to have patients enroll soon.
Yes, the aim is to start soon. We are now in the final steps of the approval. And if all goes well, correct me if I'm wrong, Barbara, we will be able to start June, July with the inclusions of the first patients.
Thank you.
I think I probably just missed this, but what was the number of patients you're looking to enroll?
120.
Yes, the sample size will be 120.
Do you think that's large enough to see a difference in your primary outcome?
Yeah, we did a sample size calculation, so normally it should be enough, but of course the inclusion criteria is pretty strict, and to find 120 patients all over Flanders it will be a challenge. So we hope that we will get the number right.
Great, and Helen, you can go ahead.
Yeah, thanks. Exciting to hear this is hopefully going to start fairly soon. I noticed on clinicaltrials.gov I think there are 4 other studies ongoing or recruiting using metformin. Do you know how your study compares to theirs in terms of Some of them I see are in progressive MS, some of them I see are in pediatrics, one actually ongoing in Toronto. But do you know how yours compares in terms of the dose of metformin and the frequency it's been given on any given day, and the outcomes that you're all using, or have you not had a chance to compare?
I am not really up to date with all the information of the dosages and the usage of metformin, but maybe Dr. Williges, she definitely knows more about.
I did a comparison. I did a comparison of all the ongoing metformin clinical trials. So the one in Toronto is indeed in pediatric MS and is a dose escalation clinical trial, so quite early stage. And then I have also seen a clinical trial which is early stage running in the USA in progressive MS patients, but not having so many clinical and MRI outcome measures as our study is having. The clinical trial in the UK is using metformin and clemastine together, and they are looking at the moment in only in relapsing MS patients who are taking Tecfidera, if I'm correct. And then I'm also aware that in the UK a big phase 3 study is going to start, which is called the Octopus clinical trial, but it's intended to run over many years, and it will test metformin versus alpha-lipoic acid, and the third one that I can't remember. That's not on clinicaltrials.gov, but I've seen that's ongoing too. So I think we actually have a bit of a different profile than some of the ongoing studies, and I think they will all add information on the use of metformin in this population.
Thank you. And one final question in the chat. So Penny was asking, what dose will you be using of metformin in your study? I guess dose and frequency.
The dosage will be 2 to max 3 tablets a day, and it will be 800 milligrams.
So we will try to titrate the patients up to 3 times daily 850 milligrams. And in case of lack of tolerance issues, we would allow to decrease the dosage to 2 times daily 850. I realize it's not so easy. You could also consider going for slow release or going for 500 milligrams 4 times daily, but they had to make certain choices, and the choices were based primarily on calculations of the dosage in the animal studies that were done in the UK, and on the fact that 3 times daily use seems feasible in clinical practice.
Great. So I guess one last question from Eline, and then we have to move to the next talk.
Hi, thanks. You're a really interesting study, really interesting to hear about it. I noticed that you have an upper age limit of age 70, and I'm just interested, because you have all the other inclusion criteria, why you set an upper age limit.
That's mainly because of safety, because we know that renal function may decrease depending on the age, and when using then metformin, that may increase potentially adverse effects. And the other issue is that with increasing age, of course, we will have potentially other factors influencing physical abilities or cognitive abilities of patients, and that's why we put the upper age limit.
Okay.
Thank you very much. Very interesting. So if the authors can just take a look in the chat, there's one other question. So if you can answer that in the chat. So our next speaker is Dr. Vinicius Schoeps. Sorry if I said that wrong. So his title is called Repurposing NAC or N-Acetylcholine or N-Acetylcysteine for Neuroprotection and Progressive MS, Rationale and Clinical Trial Design. And he is a research fellow at the University of California, San Francisco in the United States, working with Dr. Emmanuel Wobont. And he is a Brazilian-Belgian neurologist who earned his medical degree, completed a neurology residency and clinical neuroimmunology fellowship at a number of institutions, including in Brazil, and did an MPH in epidemiology degree at Harvard, and is now at UCSF researching risk factors for MS development and drivers of MS disease activity and progression. So welcome. Thank you.
Thank you, Dr. Christko, for the kind introduction. I'll just share my screen. Can you see my screen?
Yes, looks perfect.
Yes. Okay. Thank you so much. So in this talk, I will briefly introduce some of the advantages of repurposing drugs and focus on the potential of using N-acetylcysteine for neuroprotection in MS. So I have no disclosures in relation to this presentation, and starting with drug repurposing. So drug repurposing aims to identify new uses for drugs that either have already been approved or are still under investigation. And it is of interest because of two of its main advantages. Number one, that it shortens the developmental timeline. And as you can see in the diagram, most of the preclinical testing will have already been completed by the time you're investigating this repurposing compound. And that leads to your second advantage, that the safety assessment and even the formulation development have also already been done. And this will lead to a substantial decrease in the chance that the compound will fail, at least from a safety standpoint. And those two advantages lead to the potential to win regulatory approval in less than half the time and at a quarter of the cost when compared to a non-repurposed drug. And there are many examples of successful repurposing in the literature. Most had their indication changed due to retrospective analysis of adverse events, such as minoxidil and rituximab, that's so dear to us in neuroimmunology. But there are plenty of other strategies that we can use to help us identify potential successful candidates, ranging for experimental approaches with in vitro compound screening, to computational approaches where similar pathways or molecular structures, even transcriptional profiles can be matched. And that's of interest for us looking at oxidative stress and MS. Because when we look at the transcriptional profile and neuroinflammation, as we can see in our left here, there's a cluster of microglia, that's number 5 here, and macrophages, that's number 1, that have upregulated their key producer of reactive oxygen species marker gene in mice EIE models. And that same cluster had upregulated their antigen presentation marker and inflammatory marker gene. And it's interesting also to mention that this oxidative stress marker gene was selected in this study because when it was depleted, it exerted a protective effect in EIE models. So this suggests that there is a subpopulation of innate immune cells that's involved in oxidative injury and neuroinflammation that on a subsequent gene network analysis ultimately target the glutathione metabolism. And glutathione, or GSH, is an important antioxidant scavenger of reactive oxygen species and work as a frontline defense against oxidative stress. And during this defense process, there's a loss of GSH. So its reduced levels can serve as a marker of the oxidative stress itself. And as you can see in this MRI spectroscopies, that subjects that were in the progressive forms, either PPMS or SPMS, had lower concentrations of GSH, so meaning that there's a more pronounced oxidative stress ongoing in comparison to their RRMS counterparts, which is particularly more evident at the frontal or parietal frontal regions. And the role of oxidative stress in MS has been recently tested in a phase 2 trial of lipoic acid, which is endogenously produced antioxidant. And here, 54 subjects were randomized 1-to-1 to either lipoic acid or placebo. And during this 2-year follow-up period, the patients that were under the intervention arm had an improvement in the rate of whole brain atrophy, with an almost 70% reduction in the atrophy rate, which is very impressive. But it's important to notice that the intervention arm also had a significantly larger baseline whole brain volumes, and that the compound that was used to add the yellow color for the matching placebo quercetin actually could have contributed to neuroinflammation and might have exaggerated the observed effect. And N-Acetyl cysteine, or NAC, is another compound with antioxidant properties. So NAC is a precursor of GSH, and it's interesting because GSH itself cannot be taken up by neurons, but NAC can and may restore GSH levels by functioning as a cell-permeable source of cysteine, which is the rate-limiting substrate for the synthesis of GSH. So ultimately, the GSH is oxidized to GSSH, and during this process, it can convert the hydrogen peroxidase into water and decrease mainly lipid peroxidation. And when we look at the CSF concentrations after neural challenge, we can see that as we increase the dose of NAC from 7 milligrams per kilo to 70 milligrams per kilo, there's a substantial increase from baseline to after 2 days of usage when we compare white to black columns, and a subsequent increase in CYS and GSH follows as would be expected. So meaning that the NAC crosses the blood-brain barrier at higher doses. And as a reference, NAC is used as an IV infusion in higher doses to prevent hepatic toxicity after Tylenol overdose, and as an oral formulation to decrease mucous viscosity. And it's also sold as an over-the-counter supplement, but its regulation, it's currently under review. Late last year, the FDA determined that NAC is to be excluded from the dietary supplement definition because it was approved as a new drug before it was actually marketed as a supplement. But they mention in the same letter that they intend to include it in the supplement definition if there's no safety risks identified after their ongoing review. And in MS, a phase 1 trial has been conducted with Dr. Crisco that is here with us today, where 16 progressive MS patients were randomized to placebo or NAC using 1250 milligrams 3 times a day for 4 weeks. And while the hypothesis of safety and tolerability were met, as you can see from the graph, the exploratory evaluation of change in GSH from 7T spectroscopy did not show a significant difference between NAC and placebo groups, even though it was not powered as a limited sample size. And now we're moving forward to a phase 2 trial. We're currently recruiting 98 subjects at 2 sites and administering the similar dosing scheme as an add-on for their current MS DMTs for a period of 15 months. And during this period, we're going to perform 2 brain MRIs and and also cervical spinal cord MRI, one at month 3 and the other at month 15. All the study team and patients are blinded to drug assignment, and the 1-1 randomization scheme was stratified by site and MS type, being primary or secondary progressive MS. The primary outcome is change in whole brain volume loss. And this extended interval that you can see at the beginning for the first baseline MRI, only at month 3, aims to minimize the effect of pseudoatrophy in case it occurs. So this means that if the therapy has not only a neuroprotective effect, but also an anti-inflammatory one, it could cause an initial decrease in the brain volume due to the resolution of inflammation, as we have seen with other DMTs. And with this sample size, we'll be powered to detect a 35% change in brain volume loss, accounting for a 15% dropout rate. And we are recruiting patients that are less represented in MS trials, so individuals up to 70 years old and having EDSS up to 7.0. We are also aiming to include patients that are purely progressing or less likely to have new active lesions that could potentially confound the brain volume measurements. And as NAC is still being sold over the counter, a concern is contamination of the placebo group. So as we've seen from the CSF concentration study, as only higher doses might cross the blood-brain barrier, we are more concerned with those patients that are using substantially higher doses. And I wanted to finish presenting some of our challenges. And even though patients have welcomed the add-on design with a drug that is out there for over 30 years, screening has been a challenge. I think many of the more disabled patients that have not yet come to in-person clinical encounters since the pandemic are making the assessment of progression more difficult. And as I mentioned, we have accounted for the possibility of pseudoatrophy, but we currently do not know its intensity or duration. And lastly, we do not know if the 1.5-year intervention period is optimal to detect the difference between groups. And we're considering to extend this period if funding becomes available. A longer follow-up has another advantage, that is decreasing the variability of the atrophy measurements and consequently increasing the study power. Well, in about 3 months, we should be having our first subject to complete intervention phase. And I hope that next time we will be presenting our results. Now, I would like to thank all the study team at UCSF and UC San Diego, acknowledge the Department of Defense for funding, and thank you for your attention. I'll be happy to take any questions.
Thank you very much. Another study where I'll be very interested to hear the results of, so thank you. If anyone has any questions, feel free to unmute and introduce yourself and go ahead.
I have a question. How did you handle the background disease modifying therapies in this patient group? Did you stratify for those as well or not? And are all patients on a background disease modifying therapy, or are also untreated patients allowed?
I'm sorry. We are not limiting the inclusion criteria for DMTs, so they could be on or off DMTs as long as they're on stable DMT usage for the prior 3 months before enrollment. So it's since it's a variable that we have not considered in the randomization stratification procedure. It's going to be controlled for. But it's not something we could changed by design.
And I want to add also that, working with progressive MS patients, we want to be careful for symptomatic management also. So we have factored in that we want them to be stable on medications such as dalfampridine, because it can influence their 25-foot walk at least. Possibly the DSS if there's really an effect. So there are things we have done to try to maximize kind of stability at the enrollment in the study. And we expect that the vast majority of the patients will be on disease-modifying therapy because, in the US, there's a pretty broad use of anti-CD20 agents. So I think at this point of the 30 plus patients who have been enrolled, I think that there's probably at least 25 on anti-CD20, maybe a couple on no treatment, and then the rest on S1P modulators. But vast majority on anti-CD20. So hopefully we'll be able to do a stratified analysis at some point, but maybe it won't be needed really.
Okay, thank you. Very interesting clinical trial.
And I had a question, just in light of the dose they had milligrams per kilogram in the Parkinson's CSF study, like how did you come to the dose of the current study? Because I think the milligrams per kilogram may be under that amount that was in the Parkinson's study if you compare.
Well, if we look at the Parkinson's study, there's this interval between 35 and 70 milligram per kilo interval. So we're in between those two. But if Dr. Ba wants to chime in with more information, that would be helpful.
No, I think that's, there's at this point, there's been several studies that have been used to try to come up with the dose. I think that one limitation is that some of the studies used a big IV dose to load patients, and then they went on with oral medication. Some of the studies were using actually twice a day medication. So I think at this point, it's really hard to say for sure, but because there was some signal of at least biological efficacy with a dose equivalent we picked, we felt it was reasonable.
Thanks. Okay, so we'll move to the final talk. So this is presented by Dr. Erin Longbrake. The study is titled Evaluating Short-Term Ocrelizumab for Radiologically Isolated Syndrome, the CELLO trial. And Dr. Longbrake is an associate professor of neurology at Yale University with an MD and PhD from the Ohio State University, followed by residency in neurology at the Washington University in St. Louis. And she was a Sylvia Lowry Fellow of the National MS Society in her fellowship, working with Dr. Ann Cross. She's been at Yale since 2016, and she's the Director of Clinical Research in Neuroimmunology and the Neuroimmunology Fellowship Director. So thank you.
Thanks, Kristen. Can everyone see my slides okay? Perfect. Yes. All right. And should I try to finish on the hour just to make sure I pace myself here? Or by the hour?
You could go 5 after. Yeah, it's okay.
Okay. No, I just wanted to make sure I timed myself well. Thank you. All right. Well, thanks for the opportunity to come and talk about the CELLO trial. And the CELLO study is really targeting this question of when does MS start? And would MS be preventable if one could get at it and treat it early enough in the course of the disease pathophysiology? At its heart right now, we have, as a community, decided to define multiple sclerosis as dissemination in time and space. And so by definition, we need a clinical event or clinical symptoms, physical exam findings to make a diagnosis of MS. That being said, I don't think many people in the audience would disagree that the pathophysiology of the disease begins well in advance of those first clinical symptoms. Helen was on earlier, and oh no, she's still on, and has done tremendous work in the space of the MS prodrome, identifying increased utilization of health resources, at least for 5 years prior to the MS event that leads to the diagnosis. We've known for a long time that occasionally a patient will go to autopsy and lesions that look like MS, demyelinating lesions, will be discovered at autopsy, despite the absence of clinical symptoms during life. And we know that there are asymptomatic brain lesions not infrequently discovered in close family members of people who have MS. And Jen, just to touch a little bit on the prodrome, this is a retrospectively identified condition where we take someone at the time of their MS diagnosis, you look backwards, and they've been able to do this with claims data for the most part and large scale health records, but have been able to identify that during the 5 years before those first symptoms that led to a diagnosis of MS, there's increased utilization of hospitalizations, physician visits, prescription medications, and that the reasons for those healthcare usage were, generally speaking, non-specific. They were things like fatigue, pain, headaches, GI complaints, things that would not, that are common, that are hard to prospectively give you clues of what to do, but yet these people didn't feel right. They didn't feel well, and these were the things that they went in complaining of. When someone does get an MS diagnosis, most of the time there are many lesions, and most of the time they aren't all contrast enhancing, suggesting that many of them are older than the one that causing the event in question. There's elevated neurofilament light chain levels at the time of an MS diagnosis relative to healthy individuals. And looking backwards, this is a military cohort where they were able to have serial blood specimens of people who went on to get MS. They were able to look backwards for those individuals who got MS, looking backwards, and identify that compared to people who did not get MS, as long as 6 years prior to their MS diagnosis, the neurofilament levels were slightly higher than the controls in that case series. And certainly a year before the MS symptoms, people who went on to get MS had higher neurofilament levels than controls. And that difference only increased with time. So there's biomarker evidence of damage going on even before the symptoms of MS. So how can we do better? MS is, at the end of it, it's a name. It's something that we as a community have decided to use. We've agreed upon these definitions, and we've changed the definitions over time. So how are we going to do better? How do we really get at the onset of pathophysiology? And so this is my bell curve. I think that the bell curve of MS pathophysiology is probably a lot broader than we appreciate as a field, because some people don't go on to get those clinical symptoms. And we have no idea at this point just how many people that is. We know about people with radiologically isolated syndrome. That's the presence of asymptomatic brain lesions that look like MS and often meet criteria for MS if we're just going based on the appearance. Probably before those lesions develop, there's probably immune changes, but that's hypothetical at this point in time. But until we reach a symptomatic threshold, we don't call it MS by choice, and we don't treat it as MS. Yet we know that we do better in terms of outcomes if we treat earlier in the disease course. And so I ask again, how can we do better? Would we do better in terms of outcomes if we treated before the symptoms really came on? The recent ARISE trial would argue that that is in fact the case. This study took on radiologically isolated syndrome, and it treated those individuals with dimethyl fumarate. And we're able to show that the use of dimethyl fumarate in that population prevented the clinical events suggestive of MS. So radiologically isolated syndromes at this point are something of a window of opportunity. They are not technically considered MS because of the lack of symptoms. And yet many of them do go on to get multiple sclerosis in the future. There are not any medications that are approved for the treatment of RIS. And I think rightly, many have reservations about permanently immune suppressing these individuals who, as of right now, don't have symptoms of a disease. But on the other hand, we know that earlier treatment does better. And just shifting gears just a little bit, we also know that cell depleting immunotherapies, and I'm going to speak specifically about ocrelizumab, can cause long-lasting changes in the immune system. And so in the CELLO clinical trial, we are proposing to use ocrelizumab versus placebo. We're planning to use ocrelizumab as an induction approach to therapy, with the idea that if we used B-cell depletion as an induction approach, just a short-term use of the medication, the key is early enough in the disease pathophysiology. Would we be able to effectively prevent or at least significantly delay clinical symptoms of the disease? So in the CELLO study, ocrelizumab, as I said, is being used as an induction approach. We will be giving 3 doses of study drug and then observing the participants out to 4 years. We are enrolling individuals who meet 2017 McDonald criteria for dissemination in space, and that is really the key inclusion. We are enrolling adult individuals with an age range of 18 to 55 who have not previously been treated with immunotherapy. I will note that there is not a specific requirement for high-risk features like spinal cord lesions or oligoclonal bands on spinal fluid testing. There is also not a requirement for dissemination in time, only dissemination in space. We are stratifying randomization based on high-risk features, so specifically based on spinal lesions and oligoclonal bands. So randomization will be stratified based on those 2 features. And our primary outcome is any evidence of new disease activity, and that includes both clinical and radiologic measures. So it's a combined primary outcome. We are also looking intensively at biomarkers, trying to delineate the immune features of the emergence of clinical autoimmune disease of the central nervous system, multiple sclerosis. We are also studying the impact of induction approach to using ocrelizumab in terms of how does that change the immune system over the long haul. This is the study design. Essentially, after the screening assessments, we have every 6-month visit and MRIs out to 2 years, and then annual MRIs, but still every 6-month visits out to 4 years. In addition to baseline spinal fluid testing, there are optional LPs at year 2 and 4 for individuals who are willing to do that. I note again that we're stratifying randomization based on the presence or absence of oligoclonal bands, and that all participants must have a CSF analysis as part of their workup. However, we are allowing historical results to serve this purpose for individuals previously diagnosed with RIS. And worked up for RIS in the past. So as long as the original records can be provided, then we are able to accept those. And that decision was, again, to hopefully help people decide to participate in the study. A subset of the sites for CELLO are participating in an immunologic sub-study where we are doing single-cell RNA sequencing from paired blood and CSF. And any sites that do, and any CSF that is obtained during the study will be banked for future biomarker analyses as well. We have a somewhat unique recruitment strategy for the CELLO study. In addition to people who are known to have RIS, of course, those can be included. We have decided to go out and look for RIS, and this builds on the observation that close family members of individuals with MS may be more likely to have asymptomatic brain lesions themselves. And so we are offering the opportunity for close family members of MS patients to be pre-screened. So this is open to a close family member of someone who has multiple sclerosis, that's defined as a first-degree family member, a parent, sibling, or child, who otherwise meets the study inclusion criteria and wants to know if they have brain lesions that are concerning for MS, number 1. And number 2, that they are willing to say that if I did have these lesions, I would want to join this research study and do something about them. And for individuals who meet the criteria, they are allowed to have a non-contrasted brain MRI as part of this pre-screening process, along with a blood draw and baseline assessments. And if we discover that they have lesions meeting criteria for RIS, they will enter the full study. If they do not, they will be followed prospectively through the duration of the study with annual phone check-ins throughout the study. This is again reiteration of our inclusion and exclusion criteria. Our outcomes, once again, we have clinical outcomes, Those are in terms of clinical assessments, including EDSS. There are patient-reported outcomes with the NeuroQOL and their cognitive screen with simple-digit modality testing. MRIs of brain and cervical spine are done throughout the study and will be quantified with the usual quantification and volumetrics. Most of our sites will have either central vein with Blair Star or SWI, so that at least for these weren't required sequences, but we do think that we'll be able to get those for the majority of sites. And therefore, we'll have the capacity to look at some of the rim-enhancing lesions and central vein lesions as well. We have quite a few biomarker assessments. These are listed, but we expect that others will also be done as we have building a repository of a variety of biospecimens for the study. There will be about 20 sites for CELLO. About 8 of them are already activated with a half a dozen more close to activation. You can see that we're spread across the country reasonably well. And we have a patient-facing website, www.cellostudy.org, which will also list all of our sites as well as contact information for anyone who's interested in the study. And I will close there. We do have, as I said, the study is open for enrollment. 8 of our sites are active. We have a handful of patients already in the study, but we are still very much in the early stages of recruitment. So the more word of mouth we get, the better in terms of recruiting this rare population. But I appreciate the chance to share about the study, and I'm happy to take any questions.
Thank you, Erin. That's so interesting and will be so helpful for our patients if you are able to fill the study requirements. So thank you. Looks like Helen has a question.
Yeah, no, really exciting to see that. Thanks for highlighting our work on the program. So obviously you're in an optimal position to prospectively follow these individuals and collect potential signs and symptoms of the prodrome, and obviously compare individuals who fulfill criteria, diagnostic criteria for MS, and those who didn't by the end of the study. I didn't hear or catch you actually talking about collection of signs or symptoms other than the quality of life measure and the cognitive metric as well. So are you collecting any of those metrics or those signs and symptoms, and how are you doing that?
Yeah, no, it's a great question, Helen. We did want to collect as much as we could. So we're doing the neuro quality of life metrics. And so we're doing that for fatigue, for satisfaction with daily life. We had a variety. I think we're doing, 6 different neuro QOL assessments, many of which are targeting some of those areas that you had identified with the prodrome. We also have kind of updates to health history. And so any new diagnoses that are being identified, we're capturing kind of new visits to specialists, all of those kinds of things we are targeting to prospectively capture as well. Those are part of the standardized questionnaire about updates to health history that we do with each participant in either the family registry or in the trial itself. So I'm hopeful that we'll be able to get a lot of the information that you guys have already highlighted really nicely.
I have another quick question, but I'll let Barbara go. I'll just verbalize it, but I think you should answer Barbara's first. What did you learn from the dimethyl fumarate RIS study? And did you learn anything from that has informed your study, or lessons learned from that study that will get weaved into yours? But maybe I'm jumping in.
Well, I can do that one too. And I think the ARISE study was super interesting. I know they had a lot of trouble recruiting, and we made some intentional choices about recruitment based on the design of the ARISE, and then I always forget the name that the teriflunomide study gave themselves. As a result, our definition, quote unquote, for RIS in this study is not kind of the published definition for RIS that the consortium's been working with all along, which is in one sense a weakness in terms of comparing it, but in another sense, we're very interested in the biology of very early disease. And as such, we felt that it was justified and even necessary to go with the more sensitive, but possibly less specific criteria. So we are choosing to use the 2017 McDonald criteria and making kind of trying to stratify as much as we can for the high-risk patients. We felt that it's going to be difficult to use either dimethyl fumarate or teriflunomide lifelong in these groups of asymptomatic patients, and that is very much one of our reasons that we felt we had equipoise to continue with this study using a high-efficacy cell-depleting therapy as an induction approach, which we know there's long-lasting immunologic and clinical effects to the medication, even when given in short bursts. And whether we get more impact from that very early in the pathophysiology versus later in disease, I think is plausible, but of course we haven't done the study yet. So we're hoping to answer that question. Barbara, can I answer your question?
It was actually the same question on comparison to the inclusion criteria of the RISE trial, but thank you for the answer. And I think it's a very interesting clinical trial, especially because there are so many biological outcomes in this clinical trial. I think that makes it quite unique.
Yeah, this was it was a long haul to get this started. Ultimately, this is an investigator-initiated study. Yale is running this study with financial support and collaboration from Genentech, but at the end of the day, we're driving. So we will be driving, and we will have a lot of opportunities, I hope, to collaborate with people down the road.
Yeah, it's very impressive to organize that all out of a university. So wonderful. I have a question. With the spinal cord lesion and stratification, like what type of spinal cord MRIs will you be using? Is it clinical MRIs? I know Ji-Won-Oh's RIS study here, they found actually the majority of patients had spinal cord lesions when they looked at like PSIR sequences. So I wonder, like, what will there be standardized spinal cord MRIs, or is it like site specific?
No, that's a great question, Kristen. C-spine images are built into the study, and we're using a lot of the same, I guess. Roland Henry informed me heavily on what sequences I should do for the C-spine. So his group at UCSF is going to be the central readers for the C-spine. So cervical, at least, will have standardized, and we will have longitudinal throughout the entire study to monitor that. For thoracic spine, we didn't have the budget to do that. And so T-spine will have to rely on presence or absence as reported by clinical. So there will be some variability there. So that'll play into inclusion a little bit. And we won't have full spine every time point throughout, but C-spine, at least, I think that's an improvement, step up from what's been done previously in at least a lot of studies.
Yeah, I think that's great to have C-spine, since most studies are just brain. So that's great. Okay, any final questions? I think that's everything. So thank you so much to our wonderful speakers. So we really look forward to hopefully hearing some results at conferences in the future, and good luck with the recruitment. So thank you everyone for attending, and have a great rest of your day.
Thanks very much.
Thank you.
Thank you.